Bismillah Rahman Rahim and Bismillah Rahman Rahim. Start with the name of Allah. Today we are going to discuss the fracture of the lower limb. Fracture of the lower limb bones, the femur, hip joint, knee joint, tibia, and ankle and foot. As you know that the femur consists of the head of the femur, neck area, and the trochanteric area, then shaft of the femur, and then supracondylar region. This region is known as supracondylar region, and then the condylar part of the femur. Fracture can happen anywhere in the femur from proximal to the distal part. This slide give you a brief idea about the fracture, usually present fractures and their method of management or treatment or restoration of anatomy, how it's being done. Fracture neck of femur. This is a challenging problem. It occurs cause is very high energy trauma in young adults and high rates of avascular necrosis, which we are going to discuss in subsequent slides. And there is high rate of non-union as well. In elderly people, it is caused by the low energy trauma that such that they will fall by slip on floor, and then they have a fracture neck of femur. Brief description of the blood supply to the head of the femur. There is an extra capsular arterial ring which is formed outside the capsule. This capsular arterial ring sends ascending cervical arteries on the surface of the neck of the femur to the head of the femur, and these multiple arteries, ascending cervical arteries, makes another subsynovial intracapsular arterial ring, which gives rise to epiphyseal branches which supply to the head of the femur, the bone which is present, the tissues which are present here. And then another artery which comes from this is the fovea of the femoral head artery, which is the branch foveal artery, which is branch of the obturator artery, which comes from the pelvis, and it also supply a part of the head of the femur. This here you see the obturator artery. It has given rise to foveal artery, which comes through the ligamentum teres into the head of the femur and supplies this part of the head as well. Clinically, we are not going in detail. These commonly in elderly due to the osteoporosis. Osteoporosis is a process of weakening of the bones, which occurs with the aging process as well, and some hormonal disturbances in the females as well. It occurs due to the minor trauma in osteoporosis. The bone is weak, and when patient slip from in bathroom or from the stairs, it can have a fracture neck of femur. Many times it happens that when they slip, they have got a fracture and then they fell down. In young adults, it occurs due to the high energy trauma. We will discuss this. The patient will have pain in the hip area, and when we touch that part is going to elicit pain. This is known as tenderness. Loss of function occurs because the integrity of the bone is lost, so the hip joint function is impaired, and patient may not be able to move hip joint, may not be able to stand up, and there is a deformity and shortening and external rotation if fracture is displaced. If undisplaced, then these deformity, shortening or external rotation may be minimal or unnoticeable. Here you see this is the intact limb, and this is the limb with the fracture neck of femur, how it's lying. When patient come to the accident and emergency department, by looking at the lie of the limb, we can say that probability of fracture in the hip area is there. Patient will complain of pain in this part, and when we touch this part, and it will give rise to pain and loss of function. Patient may not be able to move the hip joint, and This is the deformity, which is external rotation and shortening is present in this limb. Gardens classification, we classify fracture neck of femur into four type: type 1, type 2, type 3, type 4. This is the Garden who has devised this or mm, produced this classification, so it is being named on his name. Type 1 is an incomplete fracture. This you see the fracture neck of femur, uh, and it's only on the lateral or superior aspect, but the medial side is looks to be intact. So this is known as type 1. And when the fracture is complete from one to other cortex, it is known as type 2, but it is undisplaced. The anatomy is still not looks to be disturbed. In type 3, one side is disturbed, one side is still in alignment. And type 4, when there is gross or complete displacement of the fracture occur, this is known as type 4. This is the x-rays of the hip joint showing fracture neck of femur in adult. This is the AP view being taken after a fall or accident. This is showing a complete fracture from one cortex to other cortex in AP view. This is classified as garden type 2 or minimally or undisplaced fractures. How we diagnose is that on history, patient may give history of road traffic accident in a young adult or old, that he might have got a slip in the bathroom or washroom or somewhere in the stairs. And the clinical examination, by looking at the limb, by moving the limb, we can see the tenderness, pain, and we do the x-rays, AP view. More commonly, we do it in internal rotation. So it's will disclose the fracture in AP. Treatment or restoration of anatomy is dependent on the age of the patient. More commonly, 60 to 65 years of age limit, which defines certain methods of treatment. If patient is up to the age of 60-65 years of age, close reduction is more commonly done, and fixation, and many sometime may require an open reduction or internal fixation. The method used is cannulated screws or dynamic hip screws. Cannulated screws, these are the metallic screws which has got a hole inside. We pass a guide wire, and on that guide wire we fix these screws. This is known as cannulated screws. Dynamic hip screw I show in subsequent slides. If patient is above 65 years of age and he is a household ambulator, then what we do is we do an hemiarthroplasty, which is the replacement of the broken head of the femur by the artificial metallic ball, and this is known as hemiarthroplasty. If patient is above than 65 years of age, he is a community ambulator and he may have some problem in the hip joint, then we do a total hip replacement. In the difference between hemiarthroplasty and total hip is that here on the head of the femur is being replaced. In total hip replacement, we do replace the acetabulum as well, and we opt for conservative or treatment for inoperable patients. This is the x-rays of a patient with fractured neck of femur here, here, and it is being fixed with cannulated screws. These are the screws which has got threads here and smooth here. These are the washers. These we apply wires up, first here, and then we pass these screws on that wire, and fracture is here, so these threads will go into the head of the femur and hold the fragments together, and with due course of time the fracture heals in 3 to 6 months. In this X-rays, you see the fracture neck of femur. It is being fixed with dynamic hip screw. This is known as, this consists of two parts. This is a thicker or a screw, and then this is the barrel with a shaft or plate of metal, which is being fixed to the side of the bone, lateral aspect of the bone, uh, with the screws here. And this screw glides inside this barrel. When patient walks or put weight, then fracture is going to be compressed, as this is not fixed in this barrel, and it has a gliding movement inside the barrel. This is known as hemiarthroplasty. What we have done is that we have removed the head, this fracture side, and replaced it with the metallic head. It is being fixed in the canal of the femur with the stem that goes inside the femoral canal, and is being fixed there with cement, or maybe with without cement, and it produces the movement as with the restoration of the anatomy. This is total hip replacement. What is being done here is that the acetabulum is also, the cup is being fit in the acetabulum, and like hemiarthroplasty, this stem is being fixed into the femoral canal, and in between there is a plastic liner which provides a gliding surface or rotating or moving surfaces between the two components, and the patient will start having a movement and start putting weight on this hip, artificial hip joints. This is known as total hip replacement. Complication, the more complication we will teach you in your subsequent postings when you come in third year or fourth year for orthopedic. What is deep vein thrombosis, what is thromboembolism. These patients can develop chest infection, genitourinary tract infection, bed sores, because they are prone to be in bed for longer period of time, because they are immobile. When the fracture heals, then they starts mobilization. Local complication, non-union. These fractures are notorious for non-union. They don't unite. The reason is their blood supply, and it goes, the fragment or head of the femur goes into avascular necrosis, because these fractures which happens in this part, they break the blood vessels, and when the blood vessels are torn, the blood supply to this part is lost, and this part goes into gangrenous necrosis and become dead. So it is known as avascular necrosis of the head of the femur, and it produces arthritis of the hip joint. Now we come to the intertrochanteric fractures. These are the fractures which are a little bit distal to the fracture neck of femur, and will show you the difference between in subsequent. These also results from a fall from direct or indirect forces, from accidents, occurs along the line between the greater and lesser trochanter. Theoretically, these are extracapsular. They are outside the capsule of the hip joint. The fracture neck of femur are intracapsular. These are being called intracapsular because the fracture is present in the hip joint. Extracapsular intertrochanteric fractures occurs through the cancellous bone, which is excellently supplied with the blood vessels and has got an cancellous area. Cancellous bone heals quicker than the cortical bone. There is also shortening and external rotation, as we see in the neck fracture. This slide show you the difference between the fracture neck of femur and intertrochanteric fracture. The capsule of the hip joint is attached here, so it is intracapsular, and capsule of the hip joint is attached here and here, so it is extracapsular, and this part of the bone is cancellous, scapular bone, a lot of cancellous bone is present here. In this part, the bone is less cancellous, cortical bone is present with a medullary cavity in this part, and less chances of union here, but the good chances of healing here in this part. Classification: the fracture, intertrochanteric fracture, is also classified into four types. When this is undisplaced, this is known as type 1, and when it is minimally displaced, the greater trochanter is intact, this is type 2. When greater trochanter and lesser trochanter are broken into pieces, then it is type 3. And when there is extension of the fracture, the greater trochanter is broken, lesser trochanter is broken, this is the proximal part, and the fracture is extending into the subtrochanteric area, this is known as type 4. This is the X-ray AP view and lateral view. This is the greater trochanter, this is lesser trochanter, this is the proximal part, and this is the distal part. Here you can see the oblique kind of fracture here in the lateral. Recommended treatment or restoration of anatomy is close reduction, or sometime with open reduction and internal fixation. More commonly used device here for fixation is DHS, dynamic compression heavy screw. If the patient is unoperable or inoperable or unfit for surgery, then we do a skeletal traction or skin traction for 6 to 8 weeks. This is the example of type 2 fracture with intact greater trochanter. Type 2 or type 3 fracture. This is the fracture, this is lesser trochanter, this is greater trochanter, and it is being fixed with DHS. This device is known as DHS. This is the AP view and this is lateral view. There some fragments are being fixed with this cannulated screw as well in combination with the DHS. Fracture shaft of the femur. We come to the next region of the femur. Is this results from high energy trauma as motor vehicle accidents, auto pedestrian accidents, or fall from height. If somebody fall from 10 feet 15 feet height, then they can break their femur, or gunshot injuries, blast injuries can produce fracture in the shaft of the femur. Clinically features: the patient may come with a shock, he may have a low blood pressure, thready pulse, maybe gasping, he have pain in the part, he has swelling or deformity in the part of the thigh. There is shortening and external rotation of the leg and foot, as we see in fracture neck of femur and intertrochanteric fractures. This slide is not for you, but to introduce the patient management in emergency room. You start developing that habit of that, how we go through some steps for patients who has got a major injuries. This is known as ATLS protocol. These are the few points given here in the slide. We check for the airway and cervical spine stabilization. Patient is conscious or unconscious, we see that airway is clear and his or her cervical spine is stabilized with collar or something. Breathing should be restored. If no breathing, then we restore the breathing by artificial methods like intubation, and breathing machines are being attached to the patient. We try to restore the circulation, maintain the IV line, and try to maintain the blood pressure, intravascular volume replacement. Disability: these patients may have major accident, so they can have a head injury as well. So we assess for neurological status with the Glasgow Coma Scale. You will become familiar with the Glasgow Coma Scale when you come in your senior classes. You must expose the patient to see the musculoskeletal injuries and dislocation, shoulder dislocation, spine injuries, hip dislocation, knee dislocation. If you have not exposed the patient, you can miss these injuries. You do certain urgent investigations, blood tests, radiology, and arrange blood for transfusions. Tetanus prophylaxis and antibiotics given if patient has got an open wounds on the body. Temporary stable immobilization should be done with a Thomas splint and skin traction with 3 kilogram weight. Close observation for complication like shock, fat embolism, and bed sores. Bed sore treatment should be started in the few hours of emergency room, not to be delayed for days or weeks when patient is being shifted to orthopedic unit for definitive treatment. Definitive treatment is open or close reduction and internal fixation. What radiography we do to assess the anatomy of the shaft of the anatomy assessment should be done by the three type of x-ray should be done if suspected shaft of femur fracture. X-ray of the shaft of femur full length, AP and lateral view. So this means that we don't have to miss any part of the femur in our AP and lateral view. X-ray of the pelvis should be done in suspected fracture shaft of the femur. X-ray of the knee joint should be taken in fracture shaft of the femur. Why I will show these things in next few slides. We do laboratory CBC, ESR, blood sugar, renal function test, liver function test, bleeding and clotting profile, urine detailed report, and sometimes hepatitis profile as well. This is the fracture femur full length AP view showing fracture in the mid shaft area AP, and the shortening takes place because overriding of the fracture fragments. This is the X-ray pelvis we have done in this AP and lateral, the X-ray pelvis to see the intactness of both the hip joints, because if fracture shaft of femur can be associated with hip dislocation as well. If hip is dislocated, then this is going to produce the morbidity and consequences which are very harmful for the patient. And here the x-rays showing AP and lateral view of the knee joint. Here you can see the fracture in the proximal part of the tibia. If you have not done x-ray knee joint in fracture shaft of femur, then you can miss these fractures as well. So it should be done on every suspected fracture shaft of femur, pelvis AP view and knee joint AP and lateral view. Orthopedic treatment of fracture shaft of femur or restoration of anatomy, we closely reduce these. We are not going to open up the fracture site and do the interlocking intramedullary nail stabilization. This is the standard treatment option in fracture shaft of femur. Open reduction, internal fixation with plate and screws I show in slides, and then external fixation in open fracture. I will show it also in slide. Skeletal traction are, this is the non-surgical treatment and more commonly done in children's when surgery is not possible for any reason of the for the patient. This is the fracture shaft of femur. This is the fracture, what you call it as a segmental fracture. The bone is broken at two sides. One side is that and one side is this. So what the surgeon have done is that it has opened up the femur from the proximal part and passed a nail from proximal fragment, middle fragment and distal fragment into the medullary cavity and locked it with two screws in the distal part and two screws in the proximal part. The purpose of these screws is that because this is the rounded rod and this transverse configuration can produce rotational movement at the fracture site. So if two screws in the proximal and two screws in the distal part is being applied, then this rotational movement is being prevented. This is the lateral view showing the restoration of the anatomy. in fracture shaft of femur. Although this was a very long fracture, starting from here, one fracture is here and one fracture is here. It is very good reduced. It is very accurately reduced and fixed with intramedullary rod. Here you see the fracture in this part of the bone, and it has been fixed with a plate and screws. This is the plate which is applied on the lateral aspect of the femur through the skin incision, separating the muscles. Screws are applied here and here, and the fracture is held stabilized with this screws, and uh, with the due course of the time the fracture is going to heal, and then this plate can be taken. This is the example of external fixator. Here is the fracture. Two pins are passed in the proximal part, two pins are passed in the distal part. There is no cutting of the skin or something. These are being introduced with the X-ray control by looking in the X-rays, and when the healing takes place, this is the united femur, a healed femur, and external fixator has been taken out from here. When it heals, then we can take out the external fixator. This is a skeletal traction. What in this we do, this is the fracture, and we pass a pin in the proximal part of the tibia and connect this pin with the some kind of weight over the pulleys which pull the leg. The weight pulls the leg, and the body weight pulls the proximal fragment here, and this become aligned. And when it heals, we take out these pins and mobilize patient out of bed. Keep this patient in bed 4 to 6 weeks, because this is the most commonly method used for fixation in children. So they heal quickly 4 to 6 weeks, and then they have been off these all the things, and this has the united femur with the good callus formation and good healing of the children. Usually we don't go for surgical treatment. We give plaster, traction as I already show you, elastic nail, and then cast for 6 to 8 weeks, and external fixator I already showed you, external fixator for 6 to 8 weeks. This is the example of a patient with a fracture shaft of femur in this part or in this part, and it's being given a plaster from abdomen to the ankle area, and this being held together by a rod of plaster in between, and within 4 to 6 weeks of time the plaster of the femur fracture will unite, and we take out the plaster. This is the skeletal traction. Again, the children has been treated by this method, kept in bed for 4 to 6 weeks, and pin passed here and being supported. The femur is supported here, and it heals quickly in 4 to 6 weeks of time. Usually in adult, it takes a very long time to heal femur shaft fractures, more than 3 to 6 months. Fracture of the distal femur, the mechanism of injury is direct violence, high energy trauma in young adults, and low energy trauma in elderly people. This is the AO group classification of condylar fractures or supracondylar fractures with intercondylar extension. Type A, Type B, and Type C. This is Type A. This is extra articular. These are the these are the condyles of the femur which makes a joint with the tibia knee joint, and this is outside. The fracture line is outside the joint. So this is known as supracondylar type A fracture. Here the one condyle is broken and the fracture line is going into the knee joint. This is type B, one condyle, medial or lateral condyle. And type C, when both the condyles are broken, this is known as supracondylar extension, and intercondylar, this is known as type. Surgical fixation is the treatment of choice because no deformity is acceptable in these. Like DHS, there is a device used here is DCS. This is has got a 95-degree angle which fix the condyles in type A and type C fractures. Leg screws for type B fractures or distal femur locking plate also used for fixation or restoration of anatomy in these fractures. Conservative treatment by skeletal traction and cast is also being undertaken when patient is not very fit. Here you see that two pins are passed here first and then a screw on these pins are passed, and these screws will hold the fragment in its anatomical position and healing takes place. This is DCS. There is a large screw passed here and then the both the condyles are being fixed with this, and a plate is applied on the side of the distal femur and fixed with the screws, and this hold the anatomy, restore the anatomy, and healing takes place in 3 to 6. This is the x-rays of another type C fracture. This is DCS like DHS, but its angle is a little bit different from the DHS and fixed with the screws to the shaft of the femur. This is the fracture area, show a good healing. Here another fracture fixed with the plate and screws, and healing has taken place in this as well. Fracture of the patella. The incidence of fracture of patella is 1% in all skeletal injuries. Mostly the age is between 20 to 50 years of age, which is an active age for people in this age. They have got a fall or something and direct trauma that can gives rise to fracture of the patella. Twice is common in male than female. Mechanism of injury is a direct blow on the knee joint or an indirect forceful contraction of the quadriceps muscle. Quadriceps is a very strong muscle. When it contract forcefully, it fracture the patella into pieces, two pieces, or maybe avulsion fracture. Clinical features, the major symptoms include pain, swelling in front of the knee joint. There is bruising, inability to straighten the knee joint because the fracture of the patella disrupt the extensor mechanism. So the patient may not be able to straighten the leg on the knee joint, and he may not be able to walk with the fracture patella. Physical examination, palpable patella defect, because patella is a very superficial subcutaneous bone. So if we touch this part, you can palpate the patella defect or fracture defect. Significant hemarthrosis because blood collect inside the knee joint. The knee joint is very much swollen and unable to perform straight leg raise, indicate failure of the extensor mechanism. This has been disrupted. These are the classification of patellar fracture. Undisplaced crack in transverse. There is a displaced fragments. This the proximal and the distal fragment has gone and is being separated by millimeters. This is the lower pole, or maybe have an upper pole fracture, and then the comminuted fracture. The patella is broken into many pieces. This is known as comminuted. These are the X-rays. This is the patella showing cracks multiple. This is the transverse break in the fracture patella. This is a bit undisplaced. Here you will see the two fragments are being separated with a big gap here, and here you can see the multiple fragments in AP view. This is the lateral view and this is the AP view showing the multiple. This is comminuted fracture. This is undisplaced transverse fracture, and this may be type 1 undisplaced. Method of treatment, non-operative treatment, what we do is that we, if the fracture is undisplaced, we apply a slender or long leg cast. We keep immobilized for 6 to 8 weeks, and then this is going to heal. Indication for undisplaced without significant displacement, then we do a non-surgical treatment. Minimal disruption of articular surface, then we do a non-surgical treatment. Intact extensor mechanism, if patient is able to do a SLR or extension, then we opt for a non. Operative treatment is open reduction internal fixation with K wires by tension band principle. This is a principle in which what we do is that we pass Kirschner wires or K wires or pins between the two fragments of the patella. Two wires, one is here and the second is here, and a loop of malleable wire is encircled or circlage wiring is being done. With the plier it is being tightened up to bring the two fragments of the patella close to each other, and is being kept with this fixation for 6 to 8 weeks or more, and then it is going to heal. So sometimes what we do is that we pass two screws like wires in the fragments of patella and reduce the fracture, and over these screws we pass a wire loop, and this is known as tension band principle. What happens is that when patient try to extend the knee joint, this band and this constructed construct is going to compress this fracture site again, so it speed up the healing. Knee dislocation. Now we come to the knee dislocation. It occurs in young adults and obese people. Sports injuries and road accidents are very common for knee dislocation. Diagnosis is very obvious because knee joint is very superficial. It's surrounded by the skin, and you can palpate the two bones. They have disrupted or have dislocated with respect to each other, and it has got a devastating complication because the neurovascular bundle is passing from behind the knee joint can be at compromise. Complication of knee dislocation is stiffness. If we have reduced the dislocation, then still the chances that the bleeding and the tissues which are injured here got a stiffness, and the movements of the knee joints are restricted. Laxity or inability due to ligament, because when knee dislocate, anterior cruciate, medial lateral collateral ligaments are become torn, and they produces the instability. Patient will complain that when he walks his knee is unstable, it moves in abnormal directions. Peroneal and tibial nerve injury, because peroneal and tibial nerve are in close proximity to the fibula and tibia, so they can get damaged. The most devastating complication is vascular compromise, injury of the popliteal artery. This chances are 20%, and compartment syndrome because of the damage to the artery as well as damage to the muscles. Compartment syndrome. Proximal tibia fractures. Incidence is most common in long bone fractures. It is associated sometimes with femur fracture. Mechanism of injury is indirect trauma and direct trauma, and pattern is like this. Proximal tibia can break. Lateral condyle fracture. Lateral condyle fracture with depression of the articular surface, only depression of the articular surface, and medial condyle fracture, and medial and lateral condyle fracture. Any condyle fracture with extension of the fragment towards the shaft of the tibia. This is known as type 6. Both condyle fracture is type 5. One medial condyle fracture is type 4. Type 3 is only depression of the articular surface. Type 2 is separation and depression of the articular surface. Type 1 is separation of the lateral tibial condyle. Here see the proximal tibia fracture and restoration of the anatomy with plate and screws, and it has been immobilized or fixed with plate and screws and heal in normal anatomy. This is another picture, the x-rays showing proximal tibia fracture. This is AP view, this is lateral view, this is the CT scan demonstrating the configuration of the fracture, and this is the post-operative x-rays, AP view and lateral view showing the restoration of the joint and restoration of the bony anatomy, and with due course of the time the bone heals and patient will again regain the normal anatomy. Now we come to these tibia shaft fractures. Tibia shaft fractures are very common. These are the pain occur at the fracture site, swelling occur at the fracture site, deformity and neurovascular status should be assessed because the close proximity of the tibial and peroneal vessels in this part of the body. Non-surgical treatment and surgical treatment. Non-surgical treatment with close reduction followed by long leg cast or cast brace for 2 to 3 months. Very long cast application, and that leads to immobilization of patient, maybe sometime bed confined for very long period of. These are the examples shown here. Long leg cast. The cast is extending from knee up to the mid thigh area and including the foot as well. Sometime how we apply this cast is that we hang the limb on the couch or operating table and then apply the plaster, and sometimes we pass the pins through the plaster and bone to keep the fragments distracted or anatomically aligned. This is an external immobilization. This is the long leg cast, again the same, and this is when the patient has started healing. In 2 months we remove this part of the plaster and make it the knee joint open up for movements so that he may not develop stiffness in the knee joint, still having a cast in the, this may be the fracture area, and immobilization in a short leg cast. This is the long leg cast, this is the short leg. Surgical treatment more commonly done, close reduction, intramedullary and nailing, standard method of treatment. Open reduction and internal fixation with plate and screws. External fixators are also used. More commonly these are used for fractures associated with wounds. This is the fracture. Here the surgeon have done intramedullary rod. Again the same as in femur, 2 screws in the proximal part, 2 in the distal part, and is being kept in this position for 6 to 8 months, and the fracture is going to heal. This is the fracture again, and it has been treated with the plate and screws. The anatomy is restored and fixed with the plates and screws. Here the fragments are being held with the screws as well. Now we come to the ankle joint. The anatomy of the ankle joint, you see the shaft of the tibia, the fibula shaft, and this is lateral malleolus, this is medial malleolus, and this is the articular surface of tibia, and this is the articular surface of fibula. It articulates with the talus in AP view, and it is in the lateral view the talus is forming a joint with the fibula. And the injuries around the ankle are unimalleolar fracture and bimalleolar fracture. Fracture of the medial malleolus and fracture of the lateral malleolus, and when both the fractures, then this is known as bimalleolar fracture. Clinically, intense pain, inability to stand on the leg, swelling and deformity may be obvious. The site of tenderness is important. If we palpate the ankle, if the tender on the medial side, we suspect medial malleolus fracture, and if tenderness on the lateral side, when we suspect the lateral malleolus fracture. At least three view to be needed for assessment: anterior, posterior, lateral, and 30-degree oblique mortise view. This is the lateral malleolus fracture. Here you see the bruising and swelling on the lateral side. And when you see swelling and bruising on both sides, then you suspect a fracture of both the malleoli. Treatment: for four guiding principle for treatment: reduce these fractures accurately, check and maintain the reduction. What we do is that we do x-rays after every 2 to 3 weeks and check that we have maintained the reduction. Anatomical reduction is required. For undisplaced fractures, conservative treatment should be done with a short leg cast, and for displaced fracture, the treatment should be with the surgical treatment, plates, screws, and wire. Here, bimalleolar fracture. This is the fracture line in the fibula, and this is the fracture line in the medial malleolus. The medial malleolus is fixed with the screw, and the lateral malleolus is fixed with the plate and the screws. And this is the post-operative wound condition on the lateral side. The short leg cast for undisplaced fractures. The ankle should be 90-degree, plaster applied, toes are kept open, and many times when the healing has taken place, the patient may be allowed to walk with the plaster for a few weeks, like non-weight bearing for 4 to 6 weeks, and then 2 weeks start weight bearing, and then when it heals, we take out the plaster. Metatarsal fractures: the crush fractures due to direct blow, a spiral fracture of the shaft due to the twisting injury, and avulsion fracture due to ligament strain, and insufficiency fractures, which is known as stress fractures due to repetitive trauma. X-rays need anterior, posterior, lateral, and oblique views. Multiple injuries are not uncommon. Undisplaced fractures may be difficult to detect, and stress fractures are also show nothing at all until several weeks later. What we do is that we do patient come with the fracture initially, X-ray is normal, and then we repeat the X-rays after 2 to 4 weeks. Then we can see the fracture. Treatment depend upon the type of the fracture and site of the injury and degree of displacement. Undisplaced fractures are to be treated by the blow knee cast or boot splint. Here you see the second metatarsal march fracture. The army recruits, which are being initially started with the march past, they develop these fractures, so it is being named as march fracture. They don't have strong bones, so when they start march past early in the morning daily for half an hour, 1 hour, then they start having pain in the metatarsals. And when we do x-rays initially, no fracture, but after 2 to 4 weeks, then we see a good callus formation around the fracture site, this showing the healing process. This is the avulsion fracture of the fifth metatarsal base. This is known as Jones fractures, and here the undisplaced fracture of the shaft of the third, fourth, and fifth metatarsal bones. These should be treated with plaster cast and for 4. Displaced fractures many times sometimes requires operative treatment with K wires and plates. And thank you very much.